Hello, hello, everybody. How you all doing today? Welcome to This Week in Supervision, and I'm so excited to present what I have to present today. And I love this title. It's called From Hugs to High Risk: Managing Boundaries, Medication, and Safety in Practice. All right, and we're talking a little bit about what was discussed in my groups this week. And what we try to do is get some test prep in. We try to a lot of times talk about ethics. We talk about real life case scenarios amongst the groups, things that people are experiencing and having challenges with. And I didn't want to skip through this one because I thought it was very important. And we're going to try to take a look and see if we can get the answers. I like to start with a test question to challenge the group. And I've been implementing even more test questions because the feedback has been that, hey, this has been helpful for me passing the exam. I just had two supervisees within the last 30 days that passed their exam, and they were talking about how helpful some of the things were that they were experiencing supervision, and the test question, how that challenged them as far as practice. And so we want to make sure we include that. But I am going to try to share my screen here if I can, and we're going to make sure that we're going to try to be brief because I've got a meeting too. Um, and we're gonna make sure that we get brief and to the point on here. But let's see if we can learn, if you don't already know, some of this information. And here we go. Here is our first question. I had a few more questions that I presented, but I'm kind of narrowing it down, right? And so this is the first one. Jordan is a licensed social worker providing grief counseling to a client who recently lost a spouse. After a particularly emotional session, the client begins crying heavily and reaches out for a hug. Jordan, wanting to provide comfort, offers a brief hug while saying, "Yeah, a brief hug while saying you're not alone." The following week, the client leans in again for a hug, but this time holds on just a little bit longer and begins attending sessions just to feel close to Jordan. Based on the NESW Code of Ethics regarding physical contact, which of the following is the best course of action for Jordan? A, continue hugging the client after sessions since it provides emotional support and is part of the therapeutic relationship. B, immediately terminate the client to protect professional boundaries from being compromised further. C, acknowledge the shift in dynamic and discuss physical boundaries with the client and clarify culturally sensitive limits moving forward, possibly consulting a supervisor. D, avoid addressing it and switch to remote sessions to fix the problem and reduce physical contact opportunities. This may seem kind of lightweight, but it's a big deal because we are caring professionals, aren't we? I mean, if you were to be real, how many times have you found yourself in a situation where either you hug the client or a client attempts to greet you or hug you, and then you have to make a decision from there? And I have a couple of nurses in my group, and we were just kind of going through this about the difference in being a nurse versus being in social work, and had they experienced the strong ethical boundary when it comes to this in the same capacity that they did in social work. And they both said, hey, it's very different. They would readily give hugs and things like that. But our ethics says differently, right? And so we have to be careful to monitor. And just in today's session, as I brought this up, one of my supervisees said that, hey, on their job, this was a problem with a male employee who actually was cited by the children for they made complaints that, hey, he's being a little touchy-feely, and there may have been no sexual intent as in this case, but we have to guard the boundary, which we just don't know the client's experience. And I've had experience with clients. One particular client I know that was not used to being touched by anyone. We even end up prescribing some things to where they could experience touch in a more healthy way that helped to balance them. And so, had I been hugging that client, it could have been confusing for them. And a lot of clients have been sexually abused, things like that. So We talked about this, and the answer for this question was actually C. Did you choose C? Dang, we're 5 minutes in already. The answer for this is C. We want to acknowledge the shift in dynamic, discuss physical boundaries. We want to talk about this and why we may need to make a pivot in this particular situation. And what I try to help my supervisees to see and to recognize is that, you know what, this is not just a situation where we're making this decision on our own, but we have ethics. We have ethics, social work ethics that bind us to certain decision making practices. And if you look into ethics, and I love this one from and I'll try to put the link to this one in the chat. But the in Massachusetts, they, you know, it's all the ethics here. And if you're preparing supervision and you're like, hey, well, what do I want to talk about? Which one do I want to talk about? You could just scroll through and then click into the one you want to present to your group. And in this case, it's physical contact. And it gives us a description of what we're supposed to do, what we're not supposed to do. Social workers should engage in physical, should not engage in physical contact with clients when there is a possibility of psychological harm to the client as a result of the contact. Well, when can it be psychological harm? Well, we just don't know, do we? Because we don't know that client's experience. And that's why it's super important to maybe distance ourselves from physical contact with clients, such as cradling or caressing clients. I know this is difficult because some of us are doing it, right? Social workers who engage in an appropriate physical contact with clients are responsible for setting clear, appropriate, and culturally sensitive boundaries that govern such physical contact. Now, again, what is appropriate physical contact? Well, we just don't know all the time what that means because it may mean something different to the client's experience. And I'm being realistic from the standpoint of some of us work in environments like hospice, where you become like family. And so, things happen differently. So am I saying that in no situation should you be hugging? And kids come up to you, the kids that you're working with, and they want to hug you and things like that, right? Um, Am I saying you should never do that? I'm not saying anything. I'm just showing you what the ethics say. And so we have to be mindful of that because sometimes it may not be harmful. But if it does become harmful, for whatever reason, randomly, guess who's on the hook? So this is something that we need to pay attention to, and it is part of our social work ethics. All right, let's see if we can dive into another scenario. And at this time, I would say, are there any questions? And that's when we start having a lot of feedback from the group about things many times that they have encountered or have questions about, right? So we have another client, Mr. Curtis, and we had more information on Mr. Curtis. I hope you all can see him. But Mr. Curtis is a 48-year-old client with a history of intellectual disability and schizophrenia. He recently begun refusing his antipsychotic medications. Over the past 2 weeks, he has presented with auditory hallucinations. He's hearing voices that's telling him he's healed. In the other description, it said he God told him he was healed, so he's not taking the medications anymore, right? But he's having mild paranoid delusions, no current danger to himself at the time, but noticeably having a decline in his hygiene, engagement, and sleep. So there's been a change since he hasn't been taking his medications. His provider is considering restarting pharmacological treatment uh, and to stabilize symptoms. Okay. And so which particular intervention which particular intervention would you use in this case? Let me get back to sharing my screen. What would you choose? Um, as far as of course, we're not going to be getting a medication, but what would be most likely the prescribed medication that's going to be used for Mr. Curtis delusions and hallucinations? So I mixed it up a little bit. We've got the generic names, which are sometimes hard to identify. I don't know that this would show up on the exam, but the more knowledge, the better. Okay. So sertraline, uh, risperidone, B, C, lorazepam, and methylphenidate. if I said that right, is D. Which answer would you choose? We put it in the chat, we let them answer on Zoom, and then we start to talk about which each one what the answer actually is. And so if you chose B in this situation, you were correct. Because guess what? B is an antipsychotic commonly used for hallucinations and delusions. As a matter of fact, it's a second generational antipsychotic. These are perceived to be a bit safer. Okay. If you look at Haldol, I believe Haldol is a first gen that's still used quite a bit, but some of these first gen medications may have a bit more side effects or may not be as safe. But they still that Haldol is pretty effective. It'll sit you down. But so we see risperidone, also known as Respiridol. Okay, I believe that's the brand. And sertraline, that is an antidepressant, also known as Zoloft. Okay, so Zoloft is a SSRI, a serotonin selective serotonin reuptake inhibitor, often used for depression and sometimes anxiety, I believe, because they're switching them up nowadays. And then we have C, lorazepam. Used to prescribe that a lot in the nursing home. This is Ativan is the brand name, and that's used for anxiety to calm them down. You could get that in a pill, or they give it to you, boy, in the vein, and it has an immediate effect, right? And then we have the methylphenidate, and I can't ever pronounce that wrong, right? But that's Ritalin. Okay, and so that is not the correct answer. So, yeah, so we went through this. I hope you got that correct. Now, I like to follow up, especially nowadays, because I get support and I like to bring up new scenarios that kind of follow up with the old scenarios I brought as I'm in a sense teaching my supervisees. Okay, and so we're going to bring up another scenario with this particular client, and we're going to go through it really fast. Um, Man, I'm not going to be able to get to everything, but we'll see. So, Mr. Curtis has begun missing group activities as as the residential center and at the residential center frequently smells. He's smelling like alcohol, y'all. Staff report that he seems groggy in the mornings and often forgets conversations from the day before. Which of the following DSM-TR criteria for alcohol use disorder is most clearly suggested by his behavior? Okay, and so I'm gonna skip to the answer on this one. C, recurrent alcohol use resulting in failure to fulfill major obligations. His alcohol use is getting in the way of him being able to handle uh just his basic responsibilities. And so the question is, how many symptoms, if we're thinking about diagnosing someone with alcohol use disorder, how do you do that? How do you do if this was your client? How do you even know that he has alcohol use disorder? Where do you start? This is something our clinicians need to know coming out. They're about to be clinical social workers. They need to know the process. And so we go over that. So I just asked a random question because a lot of us are not dealing with that. How many symptoms are needed in order to meet the criteria for alcohol use disorder? How many do you think, how many symptoms do you think are needed to meet the description? And how many symptoms are just, a part of what could be considered a symptom is on that description for alcohol use disorder? How many symptoms are there total? Well, the answer is two. You only need two, but as it states here, two of the following 11 symptoms within a 12-month period. And you can find all of this in your DSM. Okay. So this helps us to understand how to get where we want to go. Okay. And we're gonna take that off right now. We're gonna disregard that for right now. So here's another question. I'm about to post it in the chat because I'm so used to posting in the chat. But here's another question. So we're trying to find out how do we screen this guy? How do we screen this gentleman, right? Okay. Uh, you know, so you're screening them to try to find out if he has alcohol use disorder, because many times we want to use tools. We want to use tools to support us. All right. So you are screening a new client for alcohol use disorder. Several brief tools exist to assist in this assessment process. Which of the following is the most widely used and recognized screening tools for alcohol use problems across clinical settings? And I suggested them to give me two. Okay, it's two that you can choose from here. Which ones would you choose? And to get right to the answer is Cage, the Cage questionnaire, and the D Audit C. Audit C. These are all tools that get us closer to understanding if our client might have a substance use disorder. And what I did was try to bring in some of the groups the PDFs that spell out a little bit of the questions so that they could be familiar with this as they go. Now, so this one would be C and D. Okay. Um, the WHO supports the audit C, or at least the audit. This is two different tools. Now, right here, we can see, and I'll see if I can. Well, I probably shouldn't do that. Um, uh, Messed up. You probably can't hear that. But let me see if I can share this real quick. So this is an example of the cage. Any of if are you familiar with the cage? Have you used the cage? Um the cage is often used as a quick tool to help us to, ballpark be able to determine if someone is meets criteria for the alcohol use disorder. Okay. So let's look at what the cage questionnaire looks like if we could play that. I probably shouldn't have done that like that, but let's go. What are the questions in the cage?
Really quick way to screen for potential alcoholism. There are 4 questions that you should ask the patient. Number 1 is, have you ever felt the need to cut down on your drinking? Number 2, have you ever felt annoyed when somebody has criticised you about drinking? Number 3, have you ever felt guilty about drinking? And number 4, have you ever needed a drink first thing in the morning to wake up, something that's known as an eye-opener? If the patient says yes to 2 or more of the questions, this should indicate a sign of potential alcoholism and should be investigated further.
All right. So that's something that we can use. It's a quick one. It's pretty much evidence based, and it doesn't want to stop.
Our first
It
guest,
doesn't want to stop. It just doesn't want to stop. Okay, here we go. And so we can use the cage. The cage would be a good one to use in this situation. One of the questions was the eye opener question. I don't know if you all are familiar with an eye opener, but this is kind of what somebody does. Like if they go to sleep, and they're out, if they have a alcohol use disorder, and when they wake up in the morning, eye opener is that, hey, I might go to the fridge or wherever you keep. I don't know a lot about whiskey, if it needs to be cooled or not, but I might go to the fridge, as just say in this situation, and grab some whiskey and have a full shot, like it's 6 a.m. You know, are you just doing that because you have alcohol use issues, or is there something behind it? We start engaging the group about that. Why are they doing that? And what you learn is that the reason why this is one of the questions is that those individuals who have dependency concerns that are really on this stuff. In other words, if I stop using alcohol in the capacity that I have been using it, I might go through withdrawal. The eye opener thing is pretty much a situation to prevent withdrawal symptoms, prevent me starting to have the adverse symptoms that make me feel like that I'm going to die, and in some cases can bring you towards death if you're not just removed. See, if someone has alcohol use problems, you don't just get them to stop using it. They need to go into an institution where that can properly be done. I had a client to lose their life in rehab because of this. They just didn't make it through the withdrawal process. And so it's kind of complicated when someone is being removed from this. But in this case, this person takes the whiskey. Why? Because they're trying to reduce the potential of having these withdrawal symptoms, and they have to do that sometimes knowingly, sometimes not, maybe, and so that's a clear sign. But for the most part, that is what we talked about. We talked about so much more. We talked about so much more, but we don't have time to share all of that today. But what I did want to acknowledge, if I can, is let's see here. Yes, if I can, is we have continuing education coming up that we want you to be aware of. And I'm going to share my screen in just a moment and show you what we have coming up. Okay. We have a few things coming up that we would like for you to be aware of. If I can get this thing to do it. Here we go. All right. So if you are a clinical supervisor and you're looking for CEUs, because it's required, right? That we have to have at least three. If we're supervisors, clinical supervisors, we have to have at least three CEUs. Um, Check us out on December 5th, and we will be having a live training. If you are looking to get those clinical CEUs, this will count towards your clinical hours, count towards your clinical supervision hours. Anybody could take this. It's going to be an awesome training. Would love to see you there. And then also we have here, um, okay, let's see. We have here the DSM training. This is an online on-demand training on the DSM-5 TR. It's called DSM-5 TR Disrupted. For those of you who are looking to meet, we have required DSM CEUs. If you're a clinical social worker, you have hours that are required that you have to take a DSM course. We would like for you to take ours. If you have any questions about that, let us know and we'll put that in the chat. But we better end off for today. And we hope to see you all again on next week. Y'all take care now.